Good evening, everyone. We're going to begin tonight's webinar. I will start by introducing myself. My name is Helen Taguri, and I'm the Manager of Patient Programs at Crohn's and Colitis Canada. I'm very pleased to have this opportunity to moderate tonight's webinar, Understanding Pain and IBD, and to learn more from our guest speakers, Dr. Alan Lomax and Irina Nistor. Please note that Crohn's and Colitis Canada will be sending you a link to the recording of tonight's webinar in the next few days. So for those of you who are new to webinars, I'm going to quickly run through the logistics of how you can ask questions. Right now, all of our participants are automatically muted so that everyone can hear the presentation and we can capture the webinar recording without audio interference. If you would like to ask a question, simply type it into the chat box. Look on the right side of your screen and you should see a questions field, and you can type your question in at any time. And if at any point during the webinar you have a question, just enter it as the question comes up, and what we will do is at the end of the presentation, we'll answer as many questions as possible. We're giving ourselves about 15 to 20 minutes to answer questions. If your question is specific to one of the presenters, please indicate that if possible. Also, if you're experiencing technical difficulties, you can type your issue into the same chat box, and we'll try our best to follow up with you directly. If you're having trouble with the audio, it might be your computer audio settings, so try calling in with the phone number provided using either a mobile or a landline. You can find the PIN after you've joined the webinar, so if you can see that, hopefully you can join in and you can hear us. Great, so we're ready to get started. Just to give you a little bit of a background around Crohn's and Colitis Canada, as an organization, we were established in 1974 by a group of concerned parents of children with Crohn's disease and ulcerative colitis. We're a national charity with more than 65,000 supporters in 80 volunteer groups and chapters across the country. Our promise is to find a cure for Crohn's disease and ulcerative colitis and to improve the lives of children and adults affected by these diseases. We want the general public to be aware of these chronic diseases and the toll it takes on the nearly 250,000 Canadians living with Crohn's and colitis. Crohn's and Colitis Canada has funded over $150 million in research to date. That makes us one of the largest funders of Crohn's and colitis research in the world. This webinar, Understanding Pain and IBD, is our second webinar of the 2018 education series and is part of our patient education programs. Other programs include the Gutsy Peer Support Program, Go Here Bathroom Advocacy Program, and the IBD Scholarship Program. We also provide educational resources that cover a variety of medical, social, and psychological topics related to Crohn's and colitis. If you'd like more information, please visit our website at www.crohnsandcolitis.ca. Now I'd like to take a moment to introduce our two speakers for tonight's webinar. First, we will hear from Irina Nistor. She is a nurse practitioner with 14 years of clinical experience in pain management and gastroenterology. Over the past 5 years, she has been a nurse practitioner in inpatient gastroenterology at Halton Healthcare, the Oakville Trafalgar Memorial Hospital. Irina also serves as an instructor in the Graduate Department of Nursing Science at the University of Toronto. Following Irina's presentation, we'll also have Dr. Alan Lomax. Dr. Lomax received his PhD from the University of Melbourne and completed his postdoctoral training at the University of Calgary. As a result of his postdoctoral research that was supported by an award from Crohn's and Colitis Canada, he was recruited to the faculty of Queen's University in 2006. He is currently an associate professor in the Department of Biomedical and Molecular Sciences and a member of the Gastrointestinal Diseases Research Unit at Queen's. Dr. Lomax's research examines how interactions between bacteria, the nervous system, and the immune system can contribute to symptoms of IBD, such as pain. This research may help devise new ways to block the neuronal changes that contribute to pain and diarrhea. Okay, so Irina, it's over to you.
Hello, everyone. Hi, Helen. Thank you so much for this opportunity, and thank you all for attending tonight's webinar. I'm hoping to provide a broad understanding on pain management and inflammatory bowel disease from a clinical perspective. And tonight's objectives, I'm just waiting on my mouse to move, will be to look at the principles of pain in inflammatory bowel disease. We'll be looking at the sources of pain in IBD, what it means to be living with IBD and pain, what are some of the known maladaptive reactions, looking at a pain from a modifiable experience perspective, and then having a better understanding how we manage pain from a pharmacological or non-pharmacological approach. When we're looking at IBD and pain, first we have to have a look at what pain is, and has been previously defined by the International Association for the Study of Pain, also known as IASP, as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. And it's kind of timely because 2018 actually marks the global year for excellence in pain education, and I'm really happy to be part of this webinar tonight. When we're looking specifically at pain and inflammatory bowel disease, pain is actually recognized as a common symptom. And although it's recognized to be a quite high percentage, up to 70% of patients reporting experiences with pain during a flare, it's also notable to realize that chronic pain also persists even in patients in remission. And the percentages provided by Halton in 2012 include 36% for patients living with ulcerative colitis, and up to 46% of patients living with Crohn disease in remission will report active pain as well. When looking at sources of pain in inflammatory bowel disease, one could classify them into inflammatory and non-inflammatory components. But before going into specific details, I would also like to mention that sources of pain in IBD also include psychological, psychosocial, obstructive, genetic, neurobiological, and these are overall factors that affect the neural perception of pain in inflammatory bowel disease. And looking at this graph, Doherty et al. In 2011 had classified it into inflammatory sources of pain and non-inflammatory sources. And inflammatory sources could be of intestinal origin, and extraintestinal manifestations of IBD also play an important role. So what do I mean by that? Is that in active inflammatory bowel disease, you can have the actual inflammatory process versus abscesses, fistulae, fissures, and even of overlap with inflammatory bowel disease, which I'll be mentioning in a few minutes as well, causing intestinal active inflammation. And then from the extraintestinal manifestations of inflammatory bowel disease, you can have ocular, musculoskeletal, or dermatological manifestations that impact the experience of pain. And then recognizing an overlap between IBS and IBD is also actively being explored by researchers and as well by us in a clinical perspective. And without going into specific molecular details, there has been believed to be related to a autonomic dysregulation, maybe some cellular damage related to neuroimmune, neuroendocrine, and Dr. Lomax will be addressing some of these elements later on tonight. From a non-inflammatory perspective, when you're looking at intestinal sources of pain, you may have elements such as stricturing disease, bowel obstruction, narcotic bowel syndrome, and also not to overlook some other elements because patients with inflammatory bowel disease are at higher risk for forming things like gallstones or kidney stones, and those will also contribute to the experience of pain. When you're looking at pain experiences in inflammatory bowel disease, it's definitely a personal experience to each and one of you. However, we understand the consequences living with IBD and pain are quite dramatic, and it can affect your quality of life. And literature supports presence of chronic abdominal pain, depression, anxiety, overall self-poor rated health. You have an increase in healthcare visits, costs associated, and also noteworthy looking at literature, the presence of associated coexisting psychiatric illnesses and associated use of opioids. And interestingly enough, smoking has also been described as a strong predictor in abdominal pain, along with affective spectrum disorders. And stress is definitely an important element in your experience with pain. Zigerty, who is a known psychiatrist in the United States, had presented this slide at a recent meeting in Toronto at the Canadian Digestive Disease Week in January 2018. And looking at some of the elements of coping with pain have been actually maladaptive. And what happens that our thoughts, behaviors, the physical symptoms, and our feelings do impact the experience living with active and chronic pain. And some of these elements are important to be acknowledged and addressed in order to improve our overall perception of pain. So some of these elements are broken down into thoughts, things like ability to cope, hypervigilance, the way it affects our self-esteem and perception of self-punishment, and some behaviors like social isolation, avoidance, reduced activity overall, our feeling anxious, having a depressed mood, anger, along with feeling overall fatigue, increased muscle tension, lethargy, and fatigue. All those can impact the overall experience of pain. So this leads into my next slide, which looks at pain being considered a modifiable experience. So the theory is that the non-visceral hypersensitivity, which is recognized in inflammatory bowel disease and pain, acts almost like in the presence of anxiety, acts as a modulator. So it actually impacts the perception of pain. And we can see how our anxiety and depression can increase the pain perception, and there is a behavioral inhibition or an activation system. And when we're looking from a perspective of positive thoughts, optimism, goal-directed care, you have positive results, and then you have an overall decrease in the pain perception and a positive uptake from a patient's experience. The first known approach, the classic approach, is certainly the pharmacological approach to pain management. And unfortunately, one does not fit all. And we certainly recommend a customized approach to each individual patient. Overall, pain management in inflammatory bowel disease is complex and it's quite challenging. When you're looking from an endoscopic or clinical remission perspective, is actually the goal of care. And the known medications in treatment of inflammatory bowel disease are aiming to inducing remission from a clinical as well as a endoscopic perspective. And then the classic inflammatory bowel disease treatments with biologics, immunomodulators, enteral therapy, corticosteroids, antibiotics, aminosalicylates still remain the main course of treatment. However, that being said, most gastroenterologists, they have little or no training or experience in actually treating pain in inflammatory bowel disease, and oftentimes the patients are not forthcoming in regards to concurrent opioid use, other illicit drug use, use of marijuana. And I certainly would encourage everybody to have an open communication with their gastroenterologist and the multidisciplinary team in order to receive the care that you deserve. When you're looking at the current practice, unfortunately, the opioids are still considered a main course of therapy. However, more research had shown that the opioids and other analgesics are actually known to compound rather than ameliorate gastrointestinal symptoms. And this is how you end up with narcotic bowel syndrome, NSAID-induced flares. And by NSAIDs, I mean non-steroidal anti-inflammatories, things common such as ibuprofen, naproxen, ketorolac, toradol. And in the process, the opioid analgesia, the narcotic use, had been proven by research to cause potential dependence, tolerance, addiction, as well as diversion. And everybody's more aware now about the current opioid crisis, and there has been a call for changes in practice and affects us all, you as a patient and us as clinicians, and we're looking more into ways of providing a better improved pain management with less side effects. When you look into a specific algorithm, if you were to look at what is the best approach to pain management, I won't be able to tell you exactly what's the best course. However, there are certain literature components that break it down into having active inflammation versus no active inflammation. And escalating therapy, it's often necessary, increasing the dose of current treatments, changing the biologics in order to achieve clinical and endoscopic remission. Certainly, specifically in Crohn's disease, that has been recommended to achieve smoking cessation, to avoid or to stop smoking. And then if you have extraintestinal sources of pain, such as arthralgias, musculoskeletal pain, acetaminophen and anti-inflammatories have been the main course of treatment. However, NSAIDs are also known to potentially cause flares, so oftentimes they are being recommended to be avoided by your gastroenterologist. From an intestinal source of pain perspective, depending on the degree of pain, you can still continue with mild analgesics such as Tylenol, or proceed towards opioids, which again, not highly recommended. The dotted line actually indicates that you should be using the agent with caution. There has been some linkage between improving or increasing your activity or physical activity, benefiting pain control as well as mood. So this is definitely currently being included for functional pain. If you have any other complications from scar tissue, adhesion, structuring disease, there may be a need for procedural interventions. And then when you're looking from a perspective of something called functional pain and functional GI disorders, this is the overlap a bit with inflammatory bowel disease. But the reality is that we do have a few other agents, and they're listed up top, things like SSRIs, tricyclic antidepressants, and tetracyclic antidepressants, SNRIs. So all these are agents that are coming from the world of psychiatry, from regulating mood and improving ultimately the quality of life and your ability to cope. And I'll be addressing some psychosocial components in a few minutes as well. When you're looking at non-pharmacological approaches, it is recognized by active and current research that increasing our exercise, our psychosocial interactions with our loved ones, meditation, yoga, mindfulness, hypnotherapy, guided imagery, all these are elements that we can introduce in our daily activities, and it is research proven to benefit patients with pain, including patients with inflammatory bowel disease. In order to achieve this, certainly there is a multidisciplinary approach. There are psychosocial care training programs. You can have telemedicine, stress management, specific addressing components of active anxiety, depression, sleep disorders. Sometimes psychotropic agents are needed, but depends on how severe the element of anxiety or depression is. I would certainly recommend a multidisciplinary approach, and as I mentioned earlier, having an open communication with your gastroenterologist, involving your nurse practitioners, your family physician, and reaching out for support in your community or other. This concludes my part. Thank you so much, and I'm looking forward to your questions.
Thank you, Irina, and thank you to Crohn's and Colitis Canada for giving me the opportunity to tell you a little bit about the science behind pain research. And I'd just like to begin once I'm just waiting for control over the slides here. Just bear with me for a second. Okay, here we go. So what I'm going to do over the next 20 minutes is tell you a little bit about the neural pathways that link the gut and the brain and signal to the brain that there's a painful stimulus in the gut. I'm going to talk a little bit about how neurons within those pathways are activated and how they communicate with one another. And the reason for doing that is because many of the pharmacological approaches to treating IBD-related pain target either neuronal activation or the synaptic communication between neurons in pain pathways. And then at the end, I'm just going to show you a couple of examples of the sort of research projects funded by Crohn's and Colitis Canada that are designed to try to come up with new ways to better treat pain associated with Crohn's disease and ulcerative colitis. So as we heard from Irina, the central nervous system is a very important modifier of the perception of pain. In fact, the brain is where the perception of pain comes from. However, there are inputs from the gastrointestinal tract via nerves that signal to those brain regions that pain is being experienced. Some of the stimuli for signals from the gut to travel to the brain are chemicals released during the inflammatory process of IBD, and also the movements of the bowel can be sufficient to cause pain in patients with inflammatory bowel disease. Within the central nervous system, as you've heard from Irina, comorbidities such as stress, your ability to cope with chronic illness, and hypervigilance can cause an augmentation of the sensation of pain. Another thing that can happen is that signals from the brain to the gut can modify both inflammation and the movements of the gut, and in so doing, feed into the signals back to the brain that lead to the perception of pain. So this cartoon here illustrates simplistically the neural pathways from the gut to the brain that lead to pain sensation. If we start on the left-hand side of the slide, you can see a cartoon representation of the gastrointestinal tract. It doesn't actually look like a tube. It's much more complex than that, of course. The black structures within the GI tract are the axons of a pain-sensing neuron. So there are neurons that lie outside of the gastrointestinal tract. In fact, they are adjacent to the spinal cord, and they project these axons, which you can think of as electrical wires, into the gastrointestinal tract. And they're specialized for the perception of noxious or painful stimuli. When there is a noxious stimulus, electricity is generated within the nerve endings in the gut, which is then propagated back towards the spinal cord, and ultimately leads to the activation of another neuron within the spinal cord, which can then project up into the brain and synapse in the regions of the brain that are associated with the perception of pain. And this is the pathway that we're going to talk about in detail over the next few minutes. So if we begin by looking in the periphery and the gastrointestinal tract, researchers around the world have shown that there are a number of different nerve endings within the wall of the gut. Many of them project to the central nervous system and the brain, but only a small minority of them are responsible for the perception of pain. The rest of them are involved in signaling to the brain important information about the nutritional state of the person, the presence of nutrients in the lumen of the gut, the normal movements of the gut in case the movements need to be sped up or slowed down in order to achieve optimal digestion of nutrients. But these pain pathways, these pain sensing neurons within the wall of the gut are perfectly situated to be affected by the inflammatory process in both ulcerative colitis and Crohn's disease. So what we have in this diagram is an illustration of the inflamed gut. So on the left-hand side is a picture of the wall of the gastrointestinal tract. And you can see little cells depicted within the wall of the gastrointestinal tract. Those are the immune cells which release cytokines or inflammatory mediators such as tumor necrosis factor alpha, which is the target for infliximab, or prostaglandin E2. And these inflammatory mediators act on the tissue to cause tissue damage, but they also act on nerve endings within the wall of the gut. And when they do that, they change the sensitivity of those pain pathways such that what normally wouldn't be a painful stimulus becomes acutely painful to the patient. And this is something we call peripheral sensitization. So this is an event where in the periphery, i.e. in the gastrointestinal tract wall, peripheral events or peripheral chemicals due to inflammation are changing the sensitivity of pain pathways such that the normal movements of the bowel become painful. It stands to reason, therefore, that preventing the effects of these inflammatory mediators to cause this peripheral sensitization could be a rational way to alleviate pain. So now I'm just going to talk very briefly about the process whereby pain sensing neurons are activated and generate an electrical event that can be communicated to the central nervous system and the brain. The electrical event is called an action potential. And you can just think of it as an electrical signal that's traveling down a wire. These wires ultimately end at a process called the synaptic terminal. And these synaptic terminals are adjacent to other neurons within the spinal cord. When there is an electrical event, an action potential, it leads to a process called synaptic transmission. And synaptic transmission is the release of neurotransmitters from these synaptic terminals onto the adjacent cells. So synaptic neurotransmitters are packaged within small globes within the nerve terminal. And upon the arrival of an electrical event, those globes are released into the vicinity of neighboring cells, and they can act on neurotransmitter receptors, which can then either excite or inhibit the next cell. And I'm telling you this because most of the drugs currently used to treat pain in IBD either act to prevent the generation of these electrical events, these action potentials in the periphery, or they inhibit the communication between those peripheral pain sensing neurons and the neurons within the spinal cord and brain. So now I'm just going to recapitulate what I've said so far. There are neurons that lie outside of the gastrointestinal tract, but that project axons into the wall of the gut that can be sensitized by the inflammation that occurs during inflammatory bowel disease. As a result, they have increased activity, and they lead to increased activation of neurons within the spinal cord, which then project into the brain and lead to the perception of pain. So with this scheme in mind, I'd like to just talk about a few of the drugs that Irina mentioned as therapies for pain. Now, non-steroidal anti-inflammatory drugs, as mentioned, are viewed with caution as a therapy for pain and inflammatory bowel disease because of the risk of precipitating flares. But drugs like ibuprofen and aspirin are effective for arthralgias, as she mentioned. And one of the ways in which NSAIDs work is that they prevent the production of some of the inflammatory mediators within the wall of the gut that lead to sensitization of these pain-sensing neurons. So they act predominantly, but not exclusively, within peripheral tissues to dampen down the inflammatory response. And they do that by inhibiting a protein called an enzyme. In contrast, opioid drugs act to relieve pain both in the periphery and they do so by inhibiting the sensitization of these pain-sensing neurons, and they do this by making the pain-sensing neurons less excitable, so they're less able to generate action potentials. They also act within the spinal cord to prevent the release of neurotransmitters which stimulate those spinal pathways to the brain. In addition to those two sites of action, opioids act within the brain to cause many other side effects, and they also can act on the smooth muscle of the gut as well. So opioids have a number of side effects, but the main pain-relieving side effects are those described in this slide. Gabapentin is a more recent addition to the armamentarium of analgesic or pain-killing drugs. Gabapentin acts predominantly within the spinal cord at that synapse between the pain-sensing neuron and the neuron within the spinal cord that projects to the brain. And the way it acts is by inhibiting the release of neurotransmitter from the pain-sensing neuron into the spinal cord. So the neuron is just as excited as it was before, but it's no longer able to communicate as effectively with the next neuron in the chain. Now, another important clinical feature that Irina mentioned was that even in patients who are in remission endoscopically from inflammatory bowel disease and biochemically appear to not have the severe inflammatory reaction that typifies the disease, continue to experience a great deal of discomfort and pain. And as Irina mentioned, between 30 to 40% of patients with ulcerative colitis and Crohn's disease continue to experience pain, even though a lot of the inflammatory damage seems to have resolved. Some of this is because of changes in the nervous system. So everyone's familiar with the idea that the nervous system is good for remembering things. That's not just a property of the parts of the nervous system that are, responsible for memory as we perceive it. There are neurons within the periphery and within the spinal cord that also undergo long-term changes that we're not necessarily made aware of that are a correlate of memory. So the hyperactivity in these peripheral pathways can continue even though the initial inciting insult of the inflammation has resolved. There are other features that contribute to the persistence of pain in patients in remission from IBD, including an association with higher levels of stress and anxiety in these patients. And there is also a predominance in that the condition is more likely to persist in female patients than males. And again, as Irina said, there are some parallels between patients with post-inflammatory pain in IBD and patients with irritable bowel syndrome, in that the frank inflammation isn't quite as evident, but the symptoms are still very much evident. And this slide sort of captures some of the interactions that are thought to be responsible. So in patients that do have psychological stressors and anxiety or depression, these psychological events lead to very real changes in the wall of the gastrointestinal tract. The epithelial barrier function that's performed by the mucosal lining cells, the epithelial cells, is less well performed during stress. And that leads to a leaky barrier, which can lead to exposure of the immune system within the wall of the gut to bacterial antigens, which can lead to a subclinical inflammation, but an inflammation that can be detected by pain-sensing neurons. In addition, stress has been shown to change the microbiota. So the bacteria, fungi, viruses, and archaea that are present in the lumen of the gut, the composition of the microbiota can be changed by stress. And there are also changes within enteric nerve pathways. So in other words, the neurons that reside exclusively within the wall of the gut and that regulate things like motility are altered by stress. And the net effect of these changes in barrier function, the microbiota, and enteric nerves can lead to changes in pain pathways and dysmotility that persist beyond the resolution of inflammation. And in doing that, maybe are responsible for at least part of this post-inflammatory pain syndrome. Because of the importance of the central nervous system in regulating all of these parameters, both the composition of the microbiota, the enteric nervous system, and the barrier function, drugs that can act in the central nervous system, such as tricyclic antidepressants or serotonin selective reuptake inhibitors, or cognitive behavioral therapy, can all have effects on the central nervous system, which ultimately changes the activities within the gut and can ameliorate some of the changes I mentioned associated with stress. And another thing that they importantly do is they allow an effective brake that already exists in the body on pain perception. So there is a neural pathway that's known as descending inhibition, which is neurons within the CNS projecting back to the spinal cord where that synapse between the pain sensing neuron and the spinal cord neuron is, and they dampen down that synapse. And this descending inhibition oftentimes seems to be less effective when people are stressed, and the addition of things like tricyclic antidepressants is thought to allow that brake to function as best it can. So in summary of this part of the talk, there are factors that worsen pain, such as the chemicals released by activated immune cells in the wall of the gut, as well as stress hormones. There are also factors within the wall of the gut that can suppress pain, and there are pathways within the spinal cord that are antinociceptive or pain killing. And then there are pharmacological agents also that can alleviate pain. And the balance between the pronociceptive or pro-pain pathways and the antinociceptive or analgesic pathways determines the severity of pain in a given patient. So the goal of research is to tip the balance toward the factors that alleviate pain. And one way of doing this is to identify the most important inflammatory mediators responsible for pain. And my colleague at Queen's University, Dr. Stephen Vanner, is a gastroenterologist who has pioneered an approach for identifying these sorts of mediators. With informed consent from IBD patients, him and his clinical colleagues collect endoscopic biopsy samples from patients with IBD. And then the mediators contained within those endoscopic biopsy supernatants are applied to cultured cells that have all the properties of neurons that sense pain in patients. And then he uses very sensitive electronics to measure the electrical activity of these neurons, so measures action potential generation, and sees whether the components of the biopsies from these patients can change the excitability or the activity of these pain sensing neurons. One of the parameters that he and I both measure is a thing called rheobase. And rheobase is essentially how much of a stimulus do you need to provide to a cultured cell in order for it to fire an action potential. So if you need to fire only a little bit, if you only need to stimulate it a little bit in order to excite it, that means that it has a low rheobase, and it means the cell is very sensitive. Whereas if you need a larger rheobase or a larger stimulus to excite the cell, you have a decrease in the pain causing effect of that mediator. So now I'm going to show you a few graphs from CCC funded research that use this approach in research on pain in IBD. So the first graph here is a measurement of that parameter called rheobase that I mentioned. And I'll remind you that a lower rheobase, a smaller rheobase, means the pain sensing neurons are more excitable. And what you can see here is that when Dr. Vanner and his colleague Charles E. Beyakanma compared biopsies from patients that underwent screening endoscopy for colorectal cancer, so we call them control because they didn't have IBD. When you compare the rheobase of cells bathed in biopsy supernatants from the control patients versus patients who had acute flares of ulcerative colitis, you can see that the rheobase is much decreased. This means these neurons have become hyper-excitable as a result of what's present in these biopsies. What Dr. Vanner and his colleague did was he blocked a number of different receptors for inflammatory mediators. And what he found was that when you genetically block the ability of tumor necrosis factor alpha to act on these cultured cells, you no longer have this low rheobase. So you reverse the hyperexcitability in response to acute flares of ulcerative colitis by blocking the actions of the cytokine TNF. So this suggests that in addition to ameliorating inflammation, drugs that target TNF alpha can oftentimes remove one of the most important inciters of pain in IBD. Another insight that the Crohn's and Colitis Canada funded research produced was that the gastrointestinal tract is a source of its own opioids. So we think of opioids in the context of medical drugs, but the receptors for opioids are present in the body because the body actually uses opioids to signal between cells. And in the inflamed bowel, there is a source of endogenous opioids, and it is the immune cells. So what we have in these data here are biopsy supernatants from patients, this time not with an acute flare of ulcerative colitis, but these are patients who have had long-standing ulcerative colitis and are in more or less remission. So they don't complain of abdominal pain. And what the Vanner lab showed was that the rheobase compared to colorectal cancer screening controls was higher. So the neurons were less sensitive in response to whatever was present within the wall of the gastrointestinal tract of patients with non-painful, more or less in remission ulcerative colitis. And they were able to block this analgesic effect by blocking opioid receptors with a drug called naloxone. So what this looks like in cartoon representation is that there's a subset of lymphocytes or immune cells that are more predominant in chronically inflamed patients that don't really have ongoing problems with pain, so not during a flare, that can release these opioid peptides. And those opioid peptides can bind the same receptors that are targeted by opioid drugs and suppress pain pathways. So one of the things that's trying to be done now in the Vanner lab is to try and harness this endogenous opioid system as effectively as possible to deliver opioids where it's needed and only where it's needed and in the quantities that are required to suppress pain, but not to cause the other side effects that are so dangerous. And the last research topic I'd like to briefly touch upon is the microbiota. So I think there's a lot of interest in the microbiota and its potential role in inflammatory bowel disease. Over the past decade, the microbiota has become a very sort of high-profile area within the scientific literature. You see front page news with various discoveries on the microbiota. And most recently in the BBC website, as you can see referenced in the bottom there was a paper that showed that 57% of the cells within the human body are actually microbial. And that goes along with the microbes within our gastrointestinal tract producing more than 100 times more genes than we do as an organism ourselves. So some people think of the human being as a vessel for this vast and diverse ecosystem in the wall of our gut. In inflammatory bowel disease, several, and I mean dozens of sequencing studies have shown that the composition of the microbiota is changed in this disease. And a very important question is whether the composition is changed because of the inflamed environment of the gastrointestinal tract, or whether the change in the microbiota is the cause of the inflammation that characterizes Crohn's disease and ulcerative colitis. Genetic studies of twins who either have or have not got inflammatory bowel disease have identified several genes that seem to predispose the twins that get inflammatory bowel disease to have that condition. And some of those genes encode proteins that the body uses to deal with and interpret the presence of bacteria. So it does suggest that the bacteria are important in inflammatory bowel disease from an immunological perspective. And this insight is being thoroughly studied as part of a long-term ongoing project that Crohn's and Colitis Canada has funded called the Genes, Environment and Microbe Project. And I'm sure there are many people listening in today who have contributed materials towards that very ambitious project. What I'm going to talk about for the next couple of minutes is just whether or not the microbes can actually influence visceral pain. And we have some evidence that perhaps they do. So the way we went about this was we collaborated with some infectious diseases doctors and microbiologists who had created a community of bacteria that they cultured from the stool of a healthy volunteer. And the reason why this community is important is because it's very consistent. It has the same composition at all times. It has 33 bacteria that, bacterial species that more or less represent the types of bacteria that are in a normal, healthy gut microbiota at equilibrium. And it's been used as a synthetic stool for stool transplants to treat Clostridium difficile infection. What we did was we extracted the chemicals being released from that healthy community and applied it to those cultured cells that I'd mentioned earlier to see what the effect on the excitability of these cells is. And what you can see here is as we decrease the dilution of the mediators from these bacteria, we see an increase in the rheobase, which I'll remind you is a decrease in the excitability of these neurons. So this substance does seem to be able to reduce excitability in pain pathways, at least in cultured cells. Importantly, it's also able to reverse the hyperexcitability in these neurons that occurs as a result of exposure of these cells to biopsy supernatants from patients with an active flare of ulcerative colitis. So you can see that the neurons exposed to both the ulcerative colitis supernatant plus the bacterial secretions is similar to the controls and very different from the ulcerative colitis. So this is proof of concept data to suggest that some of the bacteria within the wall of the gut may have an analgesic property that may be useful in IBD. We went further and we identified a single bacterial species within this community of 33 microbes that seems to be responsible for this pain-killing effect. It's a bacterium called Faecalibacterium prausnitzi. And what you can see here is the decrease in excitability in response to MET1 that is lost if we provide the secretions of this MET1 community of bacteria containing the 32 bacteria that are not Faecalibacterium and without Faecalibacterium itself. So the absence of Faecalibacterium itself leads to the loss of the analgesic effect. And this bacterium has been for several years now implicated in inflammatory bowel disease. So we know that Crohn's disease patients in particular lack this bacterium. In fact, a study that was released in the past year in the journal Gut proposed the loss of Faecalibacterium as a biomarker for Crohn's disease in particular. So we wonder, given the fact that this bacterium does seem to have analgesic effects, whether its deficit in IBD is actually a contributing factor to the pain that is associated with this condition, and whether or not replacing this bacterium, if it is lost, will alleviate pain. So this would be a sort of a very directed approach to a probiotic treatment for pain in IBD. So in summary, Visceral sensitivity or visceral pain reflects a balance between chemicals released in IBD that lead to pain sensations such as TNF-alpha and prostaglandin E2, endogenous opioids that are being released within the inflamed milieu, and maybe even now we can add to the list analgesic microbes whose products are able to suppress pain. And during inflammatory bowel disease, when there's a flare, you get an increase in the number of pain-causing inflammatory mediators accompanied by an unfortunate loss of one of those analgesic microbes. And perhaps by redressing this balance, we can go some ways towards treating pain. So with that, I will pass it on to the moderator and allow her to begin the question and answer period.
Well, thank you so much to Alan and Irina. That was an excellent presentation. I think we've been flooded with questions, so if everyone can bear with me, I'm going to try and quickly go through some of the questions, and hopefully we'll be able to get to as many as possible. I also want to apologize if some of the questions were asked right at the beginning, so if it's been answered, we'll try to skip through them. I'll skip right to this one question around arthralgia or joint pain that's caused in the hours or days immediately post-infusion of a biologic medication. Can either of you speak to the possible causes of this joint pain?
Yes, I can.
Great, thank you.
Thank you for the question. What happens is you're experiencing a delayed hypersensitivity reaction, and is very common with all biologics. It's believed to be as a result of this causes something called systemic cytokines. So there are some cells that respond to the immediate response post-biologics, and it's considered to be something called an alpha type reaction, and patients usually experience like a flu-like symptom with fever, fatigue, myalgias, or rash.
Okay, great. Thank you so much.
You're welcome.
So I had another question from an individual who's been recently diagnosed with IBD, and what they're trying to understand is what is the new normal, and at what point with their pain, sort of trying to understand what is sort of a normal amount of pain, and when should they be concerned?
I'll take that as well. I wouldn't call any pain as normal. There is certainly a baseline, and you're aware of the degree of pain you have a baseline, even in the absence of active inflammation. And as you saw from tonight's presentation, you have persistent pain even in the absence of inflammation. So I think you have to be aware what's the degree of active inflammation at the time when you're experiencing pain, what the nature of the pain, the location. It also depends if you have ulcerative colitis versus Crohn's disease. Is the inflammation active in the colon, in the small bowel? In the absence of inflammation, you may have other type of pain. If it's specific to the abdomen, it's likely related to the bowel. But you can also have a component of irritable bowel syndrome that drives your presentation with abdominal pain. And you can also have, we spoke about it earlier, about extraintestinal manifestations when you have canker sores. You may have joint pain, particularly involving your hands, your knees, your back. There's an associated component with arthralgias, and rheumatology is hand in hand with GI when it comes to inflammatory bowel disease. So I wouldn't say that normal should be associated with pain, but differentiate between the presence of pain with active versus non-active disease and other triggers.
Okay, great. Thank you so much. Alan, I have a question for you. You talked a lot about some of the fantastic research that's being done, and in terms of understanding pain specific to IBD. I'm just wondering, do you know, are there any specific pain medications or treatments that are being designed or developed specifically for IBD patients?
I don't know that I'd say that they're specifically for IBD patients, but in the pain field, people view pain as one of a number of entities. One is neuropathic pain, which is pain that results from an injury to a nerve. Another type of pain is inflammatory pain, and that would be more in line with IBD-related pain. And one of the drugs that's in clinical trials at the moment targets a receptor called, it doesn't really matter what it's called TRPV1, and it's responsible for the activation of those peripheral nerve endings within the wall of the gut or in other tissues that are inflamed. I'm not sure exactly where that drug is in the clinical trial cascade, because there's a number of sort of escalating levels of scrutiny that drugs are subjected to before they're allowed to be used on patients. But that's something that is in the pipeline. I think now, over the past few years, as we've learned more about the microbiota, I think it's maybe prompted a revisiting of the use of probiotics. So probiotics were used in patients before we really understood what the actual substrate within the wall of the gut, within the bowel, so the microbiota, we didn't really understand it well enough, I think, when we were using probiotics initially. And now that we're starting to learn a little bit more about the roles that individual microbes may be performing and which ones are, susceptible to being lost in inflammatory bowel disease, we may be able to go back in a more tailored way and use things like probiotics and new probiotics that may be able to have some effect on pain. But right now, that's probably quite a few years away, and lots of basic science testing will need to be done before that gets applied.
Okay, so sounds very promising, but still very much in the development phase.
Yeah, I think the probiotics at least, yes.
Okay. So Irina, this might be a question more for you, but there's been a number of questions around managing the pain that's as a result of some of the treatments for IBD. Can you speak a little bit about that?
Sorry.
So
how is it related to the treatment of IBD?
Yes, so pain that individuals are experiencing as a result of their IBD treatment.
I guess I'll go back to the link to the previous questions regarding post-treatment active inflammation.
Mm-hmm.
So there are a few principles there. So depends what you mean by treatment. So when you look at the biologics, it's common to have an immediate, potentially immediate reaction in regards to the cytokines formation or the cytokines response. If you're thinking at other type of treatments, things like steroids, there's certainly a risk for osteoporosis. They can have joint pain. In regards to other components of therapy and pain specific, there is not a direct link between specific treatment and pain.
Okay. All right. Thank you. Just out of curiosity, has there been much research into the link between chronic pain and IBD and fatigue?
Yes, I can also respond to that. There's a lot of research coming out from the world of psychiatry, and there are a lot of collaborative efforts between gastroenterologists, GI researchers, and psychiatric teams putting together research in regards to the impact of cognitive behavioral therapy, mindfulness. We know from previous research with pain in general that guided imagery and other positive reinforcements are beneficial to pain management in general, if it's of IBD or non-IBD component. I think we're going to see more research data moving forward, as now anxiety and depression are well recognized, being associated, actually very high incidence for patients with inflammatory bowel disease. They're not specifically Canadian data to quote at the present time, but I think we'll be hearing in the next few years more and more about the association between psychiatric disorders, dysmodulation of pain, and management of IBD.
If I may just pipe in with a little bit of speculation based on basic science research, there's quite a lot of evidence now that the microbiota within the wall of the gut doesn't just signal to the pain-sensing neurons that are immediately adjacent to where the bacteria are, they can actually produce mediators that enter the bloodstream and signal to the central nervous system. So there's this idea now that there might be such things as psychobiotics, in which bacteria can produce chemicals that affect the mood of individuals. And there's a lot of money going into research in that area across Europe and the United States. So the idea is that maybe in IBD, with Irina's comment about the increasing evidence that depression and anxiety go hand in hand with IBD, given that we know that IBD changes the microbiota, it's possible that there's a role for that change in the deteriorating mood. The other thing that's important as well is that there's an inflammatory component to a lot of these psychological problem or psychological comorbidities as well, in that some cytokines, if they can get into the brain, can lead to fatigue and things of that nature.
Great, thank you. We had a question about the use of vitamins or supplements, or even looking at diet, and just wondering if any of those can help support pain management.
I'm not aware of the link between multivitamins and pain management in general, but what happens in patients with inflammatory bowel disease, with or without active inflammation, you may have absorption issues, and then you're lacking potentially, the most common known ones are vitamin D, vitamin A, but you could have quite a bit of deficiency when it comes to micronutrients. There is a lot of speculation regarding diets, and there are a lot of books and resources about different kind of diets. The most common one, most advertised one, is the FODMAP diet. However, there is no proven research, and there is not a IBD bulletproof diet that we all should recommend and follow. So what it boils down is to having or attempting to have a healthy diet. We know that especially in flare with high fibers, you'll have more prominent diarrhea, abdominal pain, cramping. So during flares, we do recommend a low residue diet. But for the most part, we recommend a healthy diet. Do supplement with multivitamins. Do check with your healthcare professionals if you do have any active deficiencies. Particularly in Canada, we're lacking vitamin D. So the recommended dose is anywhere between 1,000 to 2,000 daily for any of us. But particularly in inflammatory bowel disease, you may be lacking vitamin D. Again, not a direct link with pain, but obviously if you're malnourished, your immune system responses are different. So I cannot explain that from a pathophysiological perspective. Maybe Dr. Lomax can comment.
I'm not really sure, to be honest. I don't think those links have been really ironed out.
Okay, thank you. Irina, you talked a little bit about the use of exercise to alleviate pain. Can you speak a little bit more about that? And if there is such thing as too much exercise, on the other hand?
No, I wouldn't recommend heavy lifting from day one when you're maybe post-operatively or you have just a flare, but the benefic component is the mental state, is the ability to think positive and bring in joy and optimism. So if that exercise for you represents going for a walk versus going for a run or biking, swimming, whatever it is that brings you joy and makes you physically active, and obviously it's dependent on your age or comorbidities, but we know that it benefits the psyche as well, the mood overall, the general psychosocial interactions, being out in the world, having that connectivity to your community, to your family. Those are all beneficials when you're looking at pain in general. So I wouldn't recommend a strenuous exercise, but whatever it is that you can start, even if it's a short walk, a brief walk, even if it's a longer walk, or actually participating with a group, going to the gym or individual, but I would not recommend isolation, even if you're pursuing, a more strenuous exercise. You can attempt yoga, whatever it is that brings you pleasure.
Great, thank you so much. I think I'll make this probably the last question for this evening, as we're running a bit short on time. We had a number of individuals asking about cannabis and whether there's been any research into the use of cannabis to treat pain in IBD. Can either of you speak to that?
It's me again. Yes, there is some research coming up. Obviously, there are some limitations in Canada as it's not legalized just yet. I'm sure it's going to be more moving forward once a few centers establish different research protocols. What we're looking at is the use of cannabis, but particularly the cannabidiol, particularly oils or vaping. We're not recommending smoking in general. So marijuana use is, at your discretion, and we know a lot of our patients do use marijuana. There has been a link with marijuana smoking and increased risk for surgery, especially when it comes to Crohn's disease. So we're definitely looking forward to more research. My understanding is subjectively, Crohn's and Colitis Canada may be looking into providing a separate seminar in regards to new changes with cannabis in Canada. So that would be beneficial.
That's great. Thank you so much. I appreciate that all of the questions that we could get to have been answered. This was an incredibly informative presentation. Thank you both for giving us your time and energy for this evening. So this ends the question and answer period for this evening. If anyone attending this evening has any other questions, please feel free to send it to learn@crohnsandcolitis.ca, and we'll do our best to respond. I want to thank our speakers again for sharing their expertise, and thanking all of our participants for your questions. As we're drawing near to the end, I just wanted to remind everyone that we will be following up with you after this webinar to get your feedback and any suggestions you may have for future topics. As Irina suggested, we will likely be doing a webinar soon on cannabis. We'll also be sending you a link to a recording of tonight's webinar, so that if you want to go back and look at any of the slides, you can do that. So this concludes tonight's webinar. Stay tuned for upcoming webinars in 2018. Please check our website for more information. And finally, we invite you to make more discoveries and breakthroughs possible. Now on its 23rd year, Gutsy Walk has raised over $35 million for research, advocacy, and patient programs like this evening. And we'd like you to be a part of it. With your support, cures for IBD are just steps away. Register now at gutsywalk.ca and join us on Sunday, June 3rd at a location near you. Thank you so much, everyone, and have a good evening.